Thank you very much for your interest in the recovery trial. This short video gives you a bit of background to the trial and to the treatments that we are currently testing. As you probably know, a novel coronavirus-induced disease was identified in China at the end of 2019, and in January 2020, the Chinese CDC identified the causal agent of this new disease as a new beta coronavirus, SARS coronavirus 2, or SARS-CoV-2 for short. The symptoms people get with this infection vary from none at all through to severe pneumonia in a minority. It has been estimated that in the UK up to 50 million people may become infected, of whom 5% may need admission, and of these 30% might need level 3 intensive care. The progression from the viral prodrome to more severe disease takes 1 to 2 weeks, offering a therapeutic window when either host-directed or antiviral treatments may be started to improve outcomes. The recovery trial has already produced results on 3 interventions. It has demonstrated that neither hydroxychloroquine nor lopinavir-ritonavir reduce the risk of death. By contrast, the trial has demonstrated that dexamethasone can reduce the risk of death significantly among patients in hospital receiving oxygen or already on mechanical ventilation at baseline. The trial continues to investigate 3 other treatments in adults. These are Azithromycin, convalescent plasma, and Tocilizumab amongst sicker patients. If you're involved in the treatment of children, the trial differs slightly from the above, so please watch the separate training video. Patients are eligible for the recovery trial if they have been hospitalised with proven or suspected SARS-CoV-2 infection, and they have no medical history that might, in the opinion of their managing doctor, put them at significant risk if they were to participate in the trial. The outcomes for the trial are all-cause mortality by 28 days after randomisation. This is the primary outcome. Secondary outcomes include the duration of hospitalisation and the need for mechanical ventilation or death among people not on mechanical ventilation at baseline. Subsidiary outcomes include the need for and duration of ventilation, renal replacement therapy, and major cardiac arrhythmias. So the treatments being tested include azithromycin, which is a commonly used antibiotic of the macrolide class, which is recognised to have some antiviral and immunomodulatory properties. Azithromycin can prolong the QT interval, so is contraindicated amongst patients with known long QT syndrome or with a known allergy to macrolide antibiotics. The side effects of azithromycin include QT interval prolongation and interaction with some other drugs, including cyclosporin and digoxin. The recovery trial is also testing convalescent plasma, and if your site is participating in this comparison, please watch the separate training video which gives more information about this. But in brief, the purpose is to test whether giving patients hospitalised with COVID-19, giving them SARS-CoV-2 antibodies in the plasma of people who have previously recovered from the infection can aid their recovery. So this is the design of the trial. So eligible patients, as I have outlined, those who have been hospitalised with suspected or proven SARS-CoV-2 infection, can be randomised into what's called a factorial randomisation, currently between standard of care, SOC, or azithromycin, AZM, and simultaneously they are also randomised between convalescent plasma or not receiving convalescent plasma. So we end up effectively with 4 groups, but each independent of each other. Patients are then followed for 28 days for the outcomes previously described, and I will talk more about the second randomisation in a moment. If a study treatment is contraindicated in a given patient, they can still be randomised into the trial, and the randomisation will allocate them to one of the other available and suitable treatments. The randomisation is simple, in other words, there is no stratification or minimisation, and the randomisation ratio is 2 in the standard care arm to 1 in each of the other arms. So returning to the design of the trial, we can see that there is a second randomisation labelled R2 on the slide, which is comparing Tocilizumab with no additional treatment. Patients are eligible for this second randomisation if they are receiving oxygen or their oxygen saturations are less than 92% on air, and their CRP is at least 75 milligrams per litre, and again there is no medical history that might, in the opinion of the attending clinician, put the patient at significant risk if they were to participate in this aspect of the recovery trial. And probably the most important one here would be clear evidence of a secondary bacterial infection as the cause of the deterioration, because Tocilizumab may worsen these. However, in the absence of clear evidence that they exist, it is reasonable to randomise people. Again, please note that these criteria vary slightly among children, so these criteria are for adults. Tocilizumab is a humanised monoclonal antibody against the IL-6 receptor, currently licensed for treatment in rheumatoid arthritis and the cytokine release syndrome after CAR T-cell therapy, which is a new treatment for hematological malignancies. The cytokine release syndrome is quite similar to the hyperinflammatory state observed in some patients with COVID-19. The main side effect of Tocilizumab is the development of other, particularly bacterial infections. So in summary, while COVID-19 is a mild disease in the majority, a significant minority require hospitalisation and face significant risks of morbidity and mortality. Recovery is currently testing 3 agents, Azithromycin, convalescent plasma and Tocilizumab, to assess their effects on major morbidity and mortality, and other arms may be added to the platform in the future. Thank you very much for listening.